So certain medications, like so brand name medications that are newer, are going to be expensive because they have the patent on them still. And so the drug manufacturer basically needs to make their money back from all the research that they did so that they could get FDA approval. But so a lot of times, like, expensive medications they don't want to cover, or they want proof that you have a specific disease state that would require you to be on that medication. Other than that, it's usually, a medication that's too soon. Those are typically the things that we see.
So today I'm joined by Jillian Dano. She is a pharmacist and owner of Sarasota Apothecary and Gulfcare Pharmacy in Lakewood Ranch. So thank you for joining me today.
Yeah, thank you for having me.
So you are an independent owner, independent of any major like CVS, Walgreens, anything like that. You own the pharmacies with another pharmacist partner of yours.
Correct. Yes.
And I guess just talk about like the Sarasota like apothecary. I know that's like an older kind of term for another name for pharmacy, but is there any difference between, you don't hear that term apothecary a lot. So what is the differences between that and, a pharmacy, just a traditional pharmacy?
So the reason we went with apothecary was for the kind of the old school feeling. And then with it being apothecary and going back to what pharmacy originally was, when we specialize in non-sterile compounding. And so that's kind of why we went with that name, apothecary, because we specialize in the compounding. We do a lot of hormone replacement therapy. But that's really why we went with that name, was just because we have the compounding lab. And that's kind of what the apothecary part means, a little bit more of the old school, actually mixing the medications and customizing things.
Is that like what they used to do back, like when you think of like the mom and pop's pharmacies, like way back when in like the 50s? And
Yeah, exactly. And the ones that had like the soda fountains and all of, yes.
So what is, you say sterile compounding, what is that?
So sterile is, you can do injections and eye drops, but ours is non-sterile. So we don't do the injections or the eye drops. We just do usually creams, suppositories, troches, rapid dissolved tablets, capsules. We can also do delayed release capsules. But yeah, the difference is just that we can't do stuff that's injectable. So no intermuscular injections, no vaccines, no IVs, and no eye drops. Yeah.
And then how did you talk about a little bit how you got started? I mean, you went to school, and then from school you went to work for did you go to work for like a chain, like a nationwide kind of?
So I actually started working in a pharmacy when I was 18, and it was an independent pharmacy. It was actually one that I grew up going to in my hometown. So I started working there, and that's kind of, to me, like really what pharmacy was the independent family-owned pharmacy. You just get more customized service, and it's more it's that one-on-one.
Like personal.
Exactly. Yeah, you get to actually know people. So really knowing your customers and really being able to help them. Versus once I went to pharmacy school, I started working I worked for Rite Aid for 1 year, and then I worked for CVS. And then I was with CVS when I graduated pharmacy school, and they had a couple of positions open for pharmacists, and one of them was in Florida. So I took the spot that was available in Florida because I have family that lives up in St. Petersburg, Florida, where I was offered the position. But working in the chain pharmacies, I realized that I couldn't provide the customer service that is why I went to school for. So being able to have my independent pharmacy, I can run it the way that I want to run it, and I can give that customer service and patient care that I originally went to school to do.
It sounds a little bit like the old style, like family practitioner, how it used to be very prevalent and the doctor knew you.
Yes.
And then more and more now, it's like these big groups are buying up all the primary care physicians. It seems kind of similar to that, where it used to be a lot more personal care from the primary physicians, and now it's more, I don't know, kind of like commercialized.
Yeah.
You know, that seems like how this pharmacy is kind of more personal. You know your customers and.
Exactly. Yeah. And the nice thing too is that we market to physicians directly and medical providers, so nurse practitioners and physician assistants. And so having that relationship with the provider and the patient, it's just the kind of like a triangle that we talk about where we can collaborate between all three. So if a patient communicates something to me, then I can, give my recommendation and then also go back to the provider. And so the three of us can kind of work together as a team. So it's very cohesive instead of, when you go to your primary care physician, they'll refer you to, some specialty. And so you're kind of just all over the place and there's not really anybody that puts everything together for you. So being able to work with the physician and the customer and having the pharmacist, it's very cohesive.
I don't know if people realize how much physicians sometimes depend on pharmacists. Like even within the hospital, they'll kind of just like antibiotic dosings and stuff like that. They may not know exactly, and the pharmacist is a lot of times determining the dosages and all that stuff. And with I know certain like cardiac medications like heparin drips and stuff, they'll just they order it. That physician orders it, but then the pharmacist is the one who's kind of managing it day to day.
Yeah, absolutely. That's kind of our specialty as a pharmacist is we know what the dosing should be. As long as you have like the pertinent information like patient weight and kidney or liver function, depending on the medication, we can really be a good source for the physicians to lean on. I actually work at a hospital down in Northport and, the physicians put in the orders, but then there's certain protocols that have to get followed. And so they might be used to prescribing a medication one way, but the hospital policy is this. And so you have to say, this is what we normally do. Or this is the normal dosage. Would you like me to go ahead and change it? Would like to update it type of thing. Also, like a lot of times physicians don't know all the drug interactions, whereas we, that's kind of another one of our specialties, and we can really help with that.
Now, were you a pharmacist before, like how long have you been practicing? Because I know now with like electronic, like when I was first a nurse, we were doing paper, like Mars, like where you had to print them out. You were initialing on the MAR, the medications. If there was any changes, you had to like cross stuff out, rewrite the medication. And now it's like everything is on the computer. We're scanning everything, which is good because, there's been times where I've, pulled the wrong med or it's the wrong dose or something gets changed and the scanning actually it catches it, for the most part. So have you been a pharmacist long enough to remember the days where there was all paper and then transition into computer? Yeah.
So for the most part, because I started working in a pharmacy back in 2004. And so at that time, people were bringing in like hard copy prescriptions. There weren't the electronic prescriptions yet. So those systems weren't set up. I've definitely seen both sides of things. And I definitely agree with the fact that, the electronic systems, it really helps with redundancy. So usually you have the technician type the prescription. Again, the doctor's office sends it over electronically. So everything that alone helps because you don't have to try to read their handwriting, because some people's handwriting, especially physicians, the more they write, the faster they go. And so sometimes the handwritten stuff is really hard to read. Yeah. So just sending stuff over electronically, it's crystal clear, like what it says, there's no question, what does this say? Like you can definitely see what it says. So that alone is very helpful to help prevent like certain mistakes from happening. And then like you had mentioned, we have to, in the pharmacy, we also have labels that print out after we type it. We scan the label. That label is assigned to a specific bottle in the pharmacy for the medication. So then we scan the medication bottle, and if it doesn't match, like it could be the same drug, but it's a different manufacturer, then it alerts you and lets you know right then and there. So there's enough, stops in place where to help prevent mistakes. Mm-hmm.
So what was it like starting your own pharmacy? Because, I mean, you're highly regulated, I'm assuming, like with the...
Yeah.
I mean, like, do you do, like, narcotics and stuff where, like, the DEA is involved? And,
Yes.
like, how did you get all of that licensing and that whole thing?
It's quite a process. I think from the time that we signed our lease, we had to, of course, do construction because there's very specific requirements. You know, you have to have a drop-off window. You have to have a pickup window. You have to also have a consultation area. And there's other signage in the pharmacy that is required to be there. So
How did you know all that?
So we have a couple of business partners, and one of them, he had actually already opened a pharmacy down in Port Charlotte. And so I actually, that's how I trained in the independent pharmacy business, was under him. But he really helped guide me through. But so basically there's, you know, all the very basic stuff of what you have to do to open a business in the pharmacy. Then you have to have an inspection by the Board of Pharmacy. So everything is in pharmacy is highly regulated by the Board of Pharmacy. So that's kind of the starting point. But then also, to get our DEA license, I had to actually go up to Tampa and do an in-person interview with a couple of DEA agents. And I go in, explain that I'm open a pharmacy, they ask questions, and then a couple weeks later you get the DEA license as well. And yeah, we do carry a little bit of narcotics. That's not definitely our specialty. But we're a combination pharmacy. So my specialty, my niche is definitely the compounding piece. But we also do bill insurances for manufactured prescriptions. So we do carry that stuff as well.
So what was that interview like? I mean, were you nervous?
I mean, I was kind of nervous, but not really, because it was like, you know, you're going to a DEA office, like I'm choosing to go there.
Yeah.
They know why I'm there. I'm trying to open a pharmacy, so they just kind of feel you out, make sure that you're legitimate, and you know, that kind of thing. So it really wasn't that bad. And
like, you're not going to be operating one of those pill mills or something where you're...
Right, exactly. Yeah, they'll ask you questions, and they also go over, like, they do some training with you as well, as far as, you know, red flags to look for, things like that. Just the kind of the basics, but they kind of reiterate, hey, this is our expectations for pharmacies and what pharmacists are supposed to do, and so that's just kind of a little refresher with that as well.
Have you seen any, like with the DEA and their narcotics, have you seen like a reduction in that, or is it still, because I know there was a time where it was really bad, there was a lot of like they call them pill mills, or, you know, is that whole narcotic epidemic like still something that you see in the pharmacy, or is it trending down? Or
so I don't end up seeing that much of it, at least at an independent pharmacy. I think more maybe chains would see that. You know,
because they can like hop around from place to place.
Yeah, exactly. And if one pharmacy doesn't have it, then they're like, oh, well, I have a profile here, so they'll go to another pharmacy in the same chain. Now, I will say, I think that they have done a good job regulating that, and I think there's not as many pill mills out there as far as the doctor's offices. When I worked up in St. Petersburg, like 10 years ago, there was actually, right before I started working at one of the CVS's, there was a pill mill, like right behind the pharmacy, basically.
I remember hearing quite a few of them in Tampa area, Tampa, St. Pete.
Yes, there are certain areas that are like hot zones, basically. Yeah. But you can imagine it's like usually where there's just a lot of people. Yeah.
I know it seemed to be like a really big problem for a while. I don't hear much about it, I guess, in the news anymore.
Yeah, I think so. Every controlled substance that we fill, whether it's one tablet or, you know, 120 for the month, it doesn't matter. Every single time that we fill a controlled substance, we're required to report that. So that gets uploaded every day.
Do you know about these, what are they called, pharmacy benefit managers? Because I'm always interested in like the business of how things work. What can you explain? Like, what is a pharmacy benefit manager? And because what I hear about them is like mostly negative, like they drive the prices up, but I don't know all about them. So what is their role, and what do they do?
Yeah, so it's actually like that's an interesting topic for sure. They're kind of like the middleman. So there's the insurance company, and then there's the pharmacy, and then the PBM is kind of like in the middle of that. So they kind of, what their job is exactly, that's a good question. I honestly don't really know. They're kind of just like that middleman. It just honestly does increase prices, and
So
as far as we can see.
do you work with them, or?
So we have
'Cause,
insurance.
people are just like coming in with prescriptions, and you run their insurance, and
Yes.
like you don't really interact with them.
So, no. So we don't interact directly with the PBMs. So they're just the pharmacy like benefit managers. I think they oversee the plans, decide what probably is on formulary, what's not on formulary. But then as far as it goes for us, if you have your insurance card with you, we can bill it. Everything's electronic. It's kind of instant. It shows us, hey, yes, they're paying for it. No, they're not. But yeah, we just take the insurance, we bill them, and then one of my wholesalers has like an organization set up where they handled most of my insurance contracts, which is really nice, because if I had to deal with every single company out there, it would just be completely overwhelming. But so they deal with most of the insurance contracts, and then there are like two or three plans that I had to personally set up my contract with them. But for the most part, it's just the initial setting up the insurance contracts, and then we bill them, and then everything else is done electronically, unless we need to call the insurance for a medication that it's coming up. Like if it says refill too soon, sometimes they can tell us, hey, it was filled at this pharmacy, here's their phone number. We call them, hey, they never picked it up. So then we have to tell that pharmacy to reverse it and kind of go back and rebill it and go from there. But we don't really deal with, the actual insurance companies all that much. It's just setting up the initial contracts, and then if we need to reach out because there's a rejected claim. But yeah, that's kind of how that goes.
What do they get rejected for?
So certain medications, so brand name medications that are newer, are going to be expensive because they have the patent on them still. And so the drug manufacturer basically needs to make their money back from all the research that they did so that they could get FDA approval. But so a lot of times, expensive medications they don't want to cover, or they want proof that you have a specific disease state that would require you to be on that medication. Other than that, it's usually, a medication that's too soon. Those are typically the things that we see.
So if something gets denied, whose responsibility is it? Do they have to? Does the patient have to go back to their doctor, or are you telling them no, they actually need it? How does it?
Yeah, so it kind of depends, but so we'll of course let the patient know, and then sometimes the insurance plans, each one's different, but sometimes they will tell us, hey, this is what's preferred, and then at that point we can reach out to the doctor's office and say, this patient's insurance prefers X, Y, or Z. You want to make that change, and then they can of course make the change. But there are other times where, yes, they have a specific medical condition and they do need that medication. So then at that point, what happens is we send paperwork to the doctor's office saying, hey, the insurance rejected it. It's a term, it's called a prior authorization. So it requires a prior authorization, and then the doctor needs to fill out paperwork that the insurance asks for. So usually it'll ask for diagnosis, things like that, to kind of pretty much just support that, hey, what diagnosis does this person have? Is this really appropriate? What medications have they tried prior that, has failed and the therapy hasn't worked for them, or it's not enough? And then at that point, it's up to the insurance company to decide whether they're going to cover it or not.
Because they have to cover, if something costs $100 and the patient's paying $10, then the insurance company, they're paying another $90, right? Or is there discounts or something like that?
There's a lot of stuff that goes on the back end, and you would think that, hey, this exactly like you said, this costs $100, the insurance is going to pay 90, and then the patient covers the other part with their copay. But sometimes it's not as black and white as that. Sometimes the insurance companies will look at what say, like, because obviously the chains are going to have, like, CVS, Walgreens, those companies have huge buying contracts with these warehouses, and the manufacturer, so they'll get stuff at a different price than what us little independent pharmacies can get. So the insurance contract might actually look at a price that, like, let's just say CVS Caremark, for example. So Caremark is insurance that's owned by CVS. And so they obviously know what they're buying the cost of the product for. So they can look at that cost and say, oh, well, if we can get it for this, then so can everybody else. Or they're just, they're going to say, well, we can get it, so why can't everybody else get it at that price? So sometimes the reimbursement is not in our favor.
Yeah, that's weird that they own I didn't know that they own an insurance company.
Yeah, that's interesting because, I don't, it's kind of, to me, it seems like a conflict of interest that shouldn't be allowed, but it's almost like a monopoly in a sense. But yeah, they're not the only ones. Like Walgreens has Express Scripts, and there's a few other ones out there too.
Yeah. So what other part of the starting the pharmacy was like you had to go through the whole DA process, and I'm sure you have to get like inspections and stuff every year, and
yes,
like can they just pop in whenever they want, kind of like they do in the hospitals for, like, they can just come by unannounced and do an inspection. And
so and things change over time. So initially, I believe the Board of Pharmacy was coming every year, but now I think it's every 2 years that they come, and so you don't know when. They just come whenever. You can kind of, 1 year.
Like that day? Do they give you a day's notice?
I have
They
no
just show
notice.
up.
Yeah, I have no notice whatsoever. They just show up when it's convenient for their schedule and they're in town, type of thing. So yeah, you have no, like, time to, like, prepare. So you just have to have everything set up at all times according to what, is required by the Board of Pharmacy. DEA oversight is there. They usually don't stop in unless there's an issue. Or they might, if they're just in town, and they might say, oh, we're going to stop by so many pharmacies while we're in this town. But yeah, Board of Pharmacy is huge. DEA is more, if something comes up, then they'll.
So what is the Board of Pharmacy, like, what's their checklist? Like, what are they looking for? They come in and they look for paperwork and like cleanliness and,
Yes. Yeah, so there's a few different things they look for. The basics being, like, all of your paperwork in place. So all of your licensure has to be, like, shown on the wall, so I have, like, a big plaque kind of thing that's got everything in there. And then they just look to make sure that everybody has a name tag or is identified for their position. They also look for, it's really just a lot of paperwork. They're going to look to make sure you have invoices that you're supposed to have. They look to make sure that, like, daily we have to have, whoever the pharmacist is on duty has to sign a log saying that they were there, the time that they were there. We have to document the fridge temperatures twice a day. It's really just a lot of paperwork and just showing that, hey, you're going through the processes and this is what you're doing. There, like, if you give vaccines, you have to have, like, a sharps container, and you have to have that in a specific area. It's just very, very much about regulations and if you're following those.
And if anything's out of place, they'll come back and check. I mean, if it's something major, they can just shut you down, I guess.
Yeah, so in theory, yes. I mean, they definitely can. Usually it's, like, something minor, and they're just like if you forget, like, one piece of paperwork, like, every quarter you have to do like certain reports. So say you missed the last one because it was, the end of the quarter was like a week ago or something, and they come in. So they're going to just have you do that report, and then if it's something minor like this, then they'll just have you email it to them. Basically just that you took the corrective action, you fixed the problem. Otherwise, they also look at like expired medications as well. So they'll check your shelf to see if there's any expired medications, including like Band-Aid. Like this sounds crazy, but certain Band-Aids that have like Neosporin in them will have an expiration because the Neosporin has an expiration date. So they will look for things like that. They try to, and it depends on the person that comes from the Board of Pharmacy, but they usually will try to find at least one minor thing. Just it like almost keeps you like on your toes. So it's like, hey, like we're serious about this, and kind of go from there.
Yeah. Can you explain a little bit about like generic versus name brands? And I don't know if you know about like the process that like a drug company has to go through to get to putting out a new drug, and then how long it has to be out before it goes generic and that kind of thing.
I learned all of that back in pharmacy school. I don't remember all of the specifics, but I can kind of say, so the brand names are when a medication first comes out, and it comes out and it's expensive for a while. And then I want to say, and don't quote me on this because I don't know the specifics, but it's usually like 10 to 15 years. There's a specific time frame where once it's approved by the FDA and starts being manufactured, that the original manufacturer has the patent on it. And then after that, eventually it goes generic. And once it goes generic, the price comes down significantly, and it's not it's not necessarily right at first, but like within a year, when multiple manufacturers can start making the generic version, that happens. And honestly, the generic there are sometimes especially when it first transitions over from a brand to a generic, it's made in the exact same like manufacturing facility. So people think, oh, well, this was made somewhere else, or no, it's literally like in the same exact building that it's being made. And so there's really, most of the time
it's like the cereal boxes. It's the same cereal, but it's, General Mills or Walmart's brand or whatever.
Yeah, exactly. So there might be something, the color might be different, or the size might be different, or the imprint it might be different. But especially initially, it's literally made in the same building as the brand.
So after like whatever it is, 10 years or 50 or however long they have the patent for, they are like obligated to release whatever chemical formula they use, or or they already know what it is, but no one else can just use it.
Yeah. So for the most part, like once medication, so when it's in the research process, it has usually like 2 letters and 3 numbers for the name. Then eventually it gets assigned a generic name, which is like, I don't want to say the chemical name because it's not, but it's kind of like, if you think of it in theory, like a chemical name. And then the brand name is like a common name, something easier to remember usually. But yeah, they pretty much will let it, I don't know if they have to let the specific formula that they use out. I don't know all the details in manufacturing. But obviously people will know what the generic ingredient is, and then it becomes available for other people to make.
So why do they make it? Why does that expire? Why does that trademark expire? Is it just so more drug companies can produce the same drug at a cheaper price? Because the original company, they have to invest a lot of money, like
right.
Sometimes billions of dollars to get that
Yeah.
drug. So I guess it makes sense. They have to make that money back.
Exactly. So I think that's really what it's about, is just letting, they have to recoup that money for all that research. Because when it comes to getting approved by the FDA, you have to have a lot of research. You have to have, different arms where there's people who received placebo, people who received the medication. You have to be able to actually prove that, these specific doses showed an improvement in X, Y, or Z. The other thing that can extend a patent is if the original manufacturing company studies for another indication. And so if they add another indication to it, then they can actually extend the patent. And so I've seen that happen a few times.
What do you remember anything specifically? Like what, like an example of?
I don't, off the top of my head, I don't remember.
So they can use it for, it seems like It seems like they would come up with something else to use it for.
Yeah. And sometimes they do and sometimes they don't. And I don't really know how that works out. Like, it's interesting too, because like sometimes medications, you start it initially for one thing, but then you realize, oh, this, like, let's just use Viagra as an example. Originally the medication, it's called sildenafil, was for pulmonary hypertension, but then a side effect, from that was like, oh, hey, I have a little bonus going on here. So things like that come up, and then they're like,
Could
oh,
be totally coincident. They just happen to find that out along the way.
Yeah.
And so they can extend that trademark because there's a new use for it.
Exactly. Mm-hmm. It doesn't I wouldn't say that happens frequently, but there are times where it does happen.
Because they may not find out everything during the clinical trials.
Exactly.
And it's released to the masses, and then you have a whole bunch of people taking it, and that's when they find out.
Yeah.
Mm-hmm. Trying to think. Another area that I did want to talk to you about, because you're, I guess, considered like an expert in one of the things that you do is a hormone replacement.
Mm-hmm. Yes.
So, and I've heard a lot about it in the news and social media and everything. I don't know hardly anything about it. So what is the latest with hormone replacement, and where it was like 10 years ago to kind of like new findings?
Yeah. So yes, this is definitely like my specialty, and I've taken a lot of time, and it's kind of like, it's my passion. So hormone replacement therapy, it's actually been around for quite some time. But there are, bioidentical medications. So they're exactly equivalent to what our body produces as far as the hormones go. So, estriol, estradiol, testosterone, DHEA, pregnenolone. And those things, those medications have been around for a while, certain ones. For example, estradiol's been around. It's been manufactured in a tablet form for a very long time. I mean, it's generic now, so it's been, quite a while. It's not anything new. And then just what we're able to do with the compounding is combine them and make them custom. There has been stuff in the past. There's different research studies out there, like the Women's Health Initiative is one of them. So what I will say, just in general, when you look at different research articles that are out there, so that particular study has brought out a lot of negative thoughts on hormone replacement therapy, but it looked at manufactured products that weren't bioidentical. So I think that's a very important distinction to make, is whether the studies are looking at manufactured synthetic medications that are hormone related and work as like similar to hormones versus what's bioidentical. So if it's bioidentical, then you're not going to have as many chances of side effects, because you still have the chance of side effects, of course, with any medication, but it's identical to what your body produces. So your body's not going to like recognize it as something that's foreign to your body. Versus with any other type of medication, there's always that chance that your body recognizes it as being foreign. So when it comes to what we do with the compounding of hormone replacement therapy, we customize it for people. And here's another difference too from being manufactured to what we do. The manufactured products are kind of the one size fits all.
So when you say manufactured product, do you mean a doctor writing a prescription for a pill?
Exactly.
And then it's 50 milligrams of whatever.
Mm-hmm.
And that's what most physicians are doing. Like they're
yes.
They're giving, like if they need hormone, they're giving most of their patients, you're getting 25 milligrams or 50 milligrams or whatever it is.
Mm-hmm.
And there's no like individualized plan.
Exactly. So it's kind of individualized because, so like example, estradiol comes in 0.5 milligram, 1 milligram, 2 milligram. But that's it. There's no in-betweens with those. And then progesterone comes as 100 milligram and 200 milligram. So you can choose whichever dosages in those ranges, and you can combine whichever. But when it comes to compounding, you can customize literally and say the doctor can prescribe pretty much any strength, and we can make it. So you can choose whichever dosage you want, and you can combine whichever. But when it comes to compounding, you can customize literally and say the doctor can prescribe pretty much any strength, and we can make it. So you can choose whichever dosage you want, and you can combine whichever. But when it comes to compounding, you can customize literally and say the doctor can prescribe pretty much any strength, and we can make it.
So how do people know that? You know what I mean? Like, if you go to the doctor and they give you a prescription, most people don't know about a compounding pharmacy that can customize. Is that like more of the doctor that should be telling them that? Like, how do they figure that out?
So a lot of people, if I think nowadays more people are being more of like their own advocate for healthcare. So if you've done research, or you have, a lot of times it just comes down to friends and word of mouth and, oh yeah, like, cause all the women are going to at some point go through menopause. And so their friends are like, oh, well, I see this provider and they prescribe something and it's custom. And for the most part, it has to come from their medical provider. And then they will recommend like, oh, they'll let them know this is a compounded prescription. It's customized for you. I have a few different pharmacies that, we recommend. And then they'll refer the patients to a compounding pharmacy.
So is most of it coming from the doctor? Is most of it coming from the doctor saying, I want to write you a kind of like non-traditional dose. I'm going to send you to this pharmacy. Or is it like the patient saying, hey, I want, telling the doctor kind of like, I want something different than what you're writing?
So it's kind of, I would say it's definitely a combination of both. So it depends on if you're lucky enough to go to one of those physicians. With compounding, especially like just hormone replacement therapy and how complicated it can get, it's not something really that is taught in school. So the provider has to take their own initiative to learn that. And again, I think it comes down to, a lot of times with certain medical conditions, there's like specific protocols to follow. But when it comes to hormone replacement therapy, it's optional. Like some people don't, to me, I think it's very important. It does have a lot of medical benefits. But it's not something that's, and a lot of times insurance companies won't pay for hormone replacement therapy because they just don't, it's not going to necessarily extend your life. So the difference with the hormone replacement therapy, and one of the reasons I really like it, it comes down to quality of life. So, but again, insurance companies aren't really about quality of life. They're about quantity. So is this going to extend your life type of thing? But that's what's nice with the hormone replacement therapy is we can address your symptoms and kind of customize things. So one example that we have are, and I can compare manufactured to compounded progesterone. We can make any strength. We can do immediate release and then delayed release as well. The manufactured products are just immediate release. So the delayed release, the benefit of that is it really helps women stay asleep throughout the night, and it helps with their night sweats and hot flashes. Like if it's waking them up, it can help prevent those throughout the night, and it can help them stay asleep throughout the night. So it improves their quality of sleep. But the manufactured product is only immediate release, and so you don't get that benefit.
So are you able to manage all this stuff, or does everything have to come from a doctor? Like, are you able to go in and, if you think they need, if they're on, like I'm just making the numbers up, like 50 milligrams or whatever, and you think, oh, I think they need 60, which is a non-traditional dose. Are you allowed to do that on your own, or do you have to like get a hold of the doctor and...
So everything has to go through, so I can definitely make recommendations. I've also, I do consultations as well. But at the end of the day, I still have to have the provider sign off on the prescription.
But people can come in and see you for a consultation, and in a sense that just allows them to become better educated about their own health, and they can kind of take that information to the physician.
Yeah, absolutely. So we can always reach out to the physician and provide the recommendation. Some offices have, especially now with, like we were talking about electronic systems now, they have patient portals. And so a lot of times they'll have the patient, the offices like to hear from the patient as well. So I recommend the patient to reach out to the office through the patient portal. And then we kind of tag team them. They kind of let them know what's going on, and then I can reach out to the office as well and ask for an updated prescription.
What about, so you talked about testosterone. You do stuff for for men too. Like so what is, like who's coming to you for like testosterone? Have they gone out and gotten tested and they're like, what's your whole theory about testosterone replacement, I guess? Because I know that, as men get older, their testosterone can, drop. So is it important to keep it at a certain level, or is it important to, not drop below a certain number?
So what I would say is so anytime I see testosterone, especially with men, being supplemented, they go through blood work. And so the blood work will kind of guide the physician or the provider into like what dosing is appropriate. I would say when it comes to hormone replacement therapy in general, both male and female, it kind of comes down to, again, like your quality of life and how you feel. So there are some women out there who have hot flashes or don't have hot flashes, or it's not significant enough to them to go to the doctor about. So same with testosterone, like for men, if it's a gradual, because usually it is gradual for both men and women, that the symptoms occur. But some men don't really, aren't bothered by any symptoms specifically. So I think when it comes to hormone replacement therapy, I think it's a personal choice. And kind of also depends on your medical history. But then I do think that anybody could benefit from supplementing hormones. Because when we're younger, our hormone levels are higher. And so as we age, they just naturally decline over time. And so to have just to feel good and to have our body function the way that it used to, it makes sense to supplement those hormones. But you don't want to do it blindly, especially like with female hormones is a little bit different because they're usually low dose. But when it comes to men and like testosterone, you usually have to use higher doses. Obviously, men produce way more testosterone. So you don't want to overdose anybody on any of them, of course. So when it comes to men and testosterone, I think it's important to monitor that blood work.
I hear about testosterone replacement all the time in like sports and stuff, because they want to get, I think some of the athletes want to get like exemptions. And so there's this balance of, well, you're like, that's part of the natural aging process is you're producing less, but then they want exemptions to get the testosterone, which I suppose helps them perform better.
Yeah.
So it's this weird, like who actually needs it? You know what I mean? Like, it's a weird thing when it comes to like sports performance.
Yeah, 100%. So when it comes to sports, that's a little bit different. And it's funny. I used to figure skate, so like I'm into sports a little bit. But yeah, what I deal with is usually it's not people who are, looking for performance enhancing. Usually, if you're on a regular normal dose of testosterone, you're not going to, get ripped going to the gym from using it. It's the idea behind hormone replacement therapy is just to supplement what your body is, and if most people, even a 20-year-old male, 25-year-old male, like who's producing a lot of testosterone, obviously if they go to the gym, there's only going to be so much development in their muscles compared to somebody who's abusing it. So there's definitely a difference there. But yeah, I mean, it's definitely interesting to, because we all know that as we age, we produce less hormones.
So when you're on hormone replacement, like male or female, is that like a lifelong thing? Because I mean, it gradually gets lower and lower and lower, right? So is it is that recommended like, for the rest of your life to kind of tweak the doses and stay at a certain therapeutic?
So I get this question a lot. That's probably one of the most common questions people have when they're starting hormone replacement therapy. Well, how long am I going to have to use this? And it's like, well, if you want to continue to feel a specific way and this is helping, then yeah, it's going to be a long-term thing. Especially, so let's just say with women, it's very important for them to start the hormones within the first 10 years. The closer to menopause, like the initiation of menopause, the better, because you prevent disease states from happening, like changes like in their cardiovascular system, loss of bone as well. So it's important to start sooner rather than later. But I do see people who, I have women in their 80s, 90s that are still using it. So it just, at some point, again, like if you're in your 90s, it all is all kind of about quality of life and how you feel.
Are there any, like who wouldn't, I guess, qualify for hormone replacement, or is there any like reasons why you shouldn't take it? I mean, I think probably for most people it's, fine if it's supervised, but is there any like, anyone that's like, no, you should stay away from it? Or
so I would say the major ones that stick out would just be if the patient has any personal history of having a hormone sensitive like cancer. That would be so like women who have breast cancer, if it was known to be a hormone positive type of breast cancer, then I would say that person would want to avoid specifically estrogens. But it's very, for the most part, and going on hormone replacement therapy, there are the risks, especially of the potential for cancer. But again, that's why we, monitor the doses and we do lower doses. We don't just start somebody on a really high dose. So that's really that's the one thing that sticks out, is just if they have a hormone positive cancer history. Everything, it's all about like pros and cons. And I will say there are people out there who have been in remission from their cancer for a long time and then choose to go on hormone replacement therapy. So it's really it's a personal choice based about quality of life, and you have to weigh the pros and cons of everything. But I will say somebody who specifically in this case, like a woman who had a history of a positive hormone cancer, they can probably still use the vaginal estrogen. For vaginal dryness is usually what it's for. It helps just rejuvenate the vaginal tissue. But it's such a low dose in our, we have receptors there locally. And so when we're using it vaginally, you wouldn't expect to see it systemically throughout your body. So if you were to do blood work, you wouldn't expect to see increased estrogen levels throughout the whole body from using a vaginal cream. And one thing I did want to mention too about the vaginal cream, so most estrogens, it's been kind of like all estradiol has had this warning about, different warnings as far as like blood clots and things like that. But that's recently just been removed from the vaginal cream because it's such a low dose. So I just think that's something that's very interesting, and that's literally just come out in the last month.
So what is the, are these supplements going to be like the future of hormone replacement? I mean, because they kind of, like you were saying, they mimic what the body is doing. So is there any new, like, I don't know, technologies or new medications that are going to make, hormone replacement even better? Or is this pretty much like...
So what I will say is that there are some technologies out there. So, I don't know if you've heard of like hormone pellets, but there's pellet therapy. So I don't know too much about it just because, I do the creams and I do the non-sterile side of things, but if you're implanting something, then it should be sterile. So I don't know the specifics on it, but I do know when it comes to pellets, they'll put it usually like in your lower back area. And then it's there for like 3 months at a time. So I would say the one thing with that is that, it's there, but you can't, like most people won't go in and remove it if you have side effects from it. So the main thing with that, technology is changing, and there's newer pellets out there with different technology, releasing technology for how the body absorbs everything. I also think there's injection forms as well that certain ones haven't been around all that much, but I think that injections may be another route. But honestly, for the most part, I think when it comes to hormones, like what you see right now, for the most part, besides maybe the pellets and injections that might change a little bit, I think this is kind of the way to go. And I don't know that there's going to be all that much all that many changes in the future, just because when you're looking at hormone replacement therapy, it's very customized for each person. And for FDA approval of something like this, you'd have to have set doses. You can't customize everything. So one thing I want to point out is that this customized hormone replacement therapy, people will say, oh, well, it's not FDA approved. And so what I would point out is that the ingredients themselves are regulated in either FDA or USP approved. But your specific dose has not been studied. So therefore, your specific dose and each dose that we make hasn't been studied. So at that point, no, your combination is not FDA approved.
So
but the ingredients are.
The FDA won't, rubber stamp it because it hasn't been tested like a standard dose.
Exactly.
Yeah. Mm-hmm. Trying to think. So just going back to your, opening your pharmacy, what was, I guess, what's been the hardest thing about it that you've had to kind of overcome? Because you're running like a pharmacy, and then all of a sudden you have your own employees, and you're running the business side, and then you have, inspections and all that. Was there anything unexpected or difficult that I guess you had to overcome when doing this?
So I think probably there's kind of two things, maybe three. So I feel like, opening the pharmacy, like I have to be the IT person. I have to be the HR person. Like I have to do pretty, everything, which obviously, that when you open a business. But there are times where it's kind of a lot to juggle. Because it's like, oh, you think you have things set up like IT wise. And then it's like, oh no, well now you need to replace your computers because, now you need Windows 11 for security purposes. And so like, that happened just this year. And it's like, oh, okay, it shouldn't be like that big of a deal. Well, there's just a lot that goes into it because, just how you have everything like wired, when we built out the pharmacy, I feel like we never have enough electrical outlets. So just trying to like wire everything through the counters and everything is interesting. But then it's like, the printer suddenly isn't working. And it's just like, silly things like that come up that are just like, oh my goodness. So I would say that. I would say the next thing that I didn't expect is probably like and I'm sorry for my staff when they watch this, but is dealing with employees and hiring employees. It's funny because like everybody's personality is different. So I have a very strong work ethic, and it's interesting when you see people, not everybody does. So it's, dealing with, and I'll just put it this way, dealing with people in general, whether it's customers, patients, pharmacists, technicians, it's just dealing with people is definitely a challenge sometimes.
Everyone has different personalities. I mean, it's like that in every job place. Everyone has different personalities and how they do things. And
people learn different ways too. So you have to definitely be able to adapt and and then other than that, I would say just there's a lot of business and things to it. It's things that come up. Oh, we're changing this now. This year you have to register your business with a different, an additional place, or just there's things that come up like that you don't expect at all. Yeah.
Have you done anything with artificial intelligence at all? Or do you see that? I mean, I suppose that would probably hit the bigger companies because it's something that they can maybe monitor all of their, like a bigger chain. They have hundreds of pharmacies nationwide that they may have to monitor. But have you done anything with it, or do you know of anything in the pharmacy world that is being done besides just like the normal computerized, kind of thing?
Yeah, so I don't have any personal experience really with, artificial intelligence in the pharmacy realm, but I guess it kind of depends on like where you want to start with, when I did work at 24-hour like CVS, we had, like a machine that would have like all the maintenance meds. So, like your blood pressure medications, your cholesterol medications, your antidepressants, things that you go through, on a daily basis, especially a 24-hour pharmacy that's busy. You're going through the same medications like over and over and over again. So, and I mean, this has been going on for a while, but that the computer, or that there's like a machine that will count the pills out and put it in the vial and label the vial. So I've seen that, and that's been the start of things for quite a while. But I think that there are limitations with that. But I think that in the future, AI is going to be a thing for sure.
I remember in nursing school, this wasn't AI, but it was kind of a new technology. They had like these little robots that would go to the different units and deliver stuff, like medication. It was which I guess they probably didn't have a tube. I mean, we have a tube system where I work now, and it's almost like a bank. Like you put the tube in and it'll send it anywhere. Maybe they didn't have a tube system, but it's like, who would have ever thought like 20 years later that the computers and AI would be, no one even thought about AI 20 years ago, but some of the stuff is crazy to see. Mm-hmm. I always try to ask everyone, what do you think in general the healthcare system, pharmacy world what is being done really good, and what needs improvement, and like how would you suggest those improvements be made?
So, kind of going back to like the electronic system. So now that they send most prescriptions electronically, I think that's been a huge improvement. Again, sometimes handwriting is just really hard to read. As far as what else, it's interesting because I always think that there's room for improvement with everything. But when it comes to like, I end up looking at things like, okay, what can I do better in my business? How can I how can things go smoother? And as far as like the whole pharmacy and medical world, I don't really have anything specific. Again, I kind of tend to look at things like, okay, what's in my control? What can I actually sit here and fix and adjust and work on? And a lot of times I feel like everything comes down to just communication. But, I think that if we could see, let's just say in the pharmacy world, I think that if we could see, so if you go to multiple pharmacies, I don't necessarily see what you fill at other pharmacies. So when it comes to drug interactions, it would be very beneficial if we could see all of the prescriptions that somebody fills. So when it comes to controlled substances, I can see what people fill anywhere they go. But when it comes to just, your regular blood pressure medication, like if you're on blood pressure medication, say blood thinners, a few different things, cholesterol medication, like if you're getting them at different pharmacies because you get a better price at one pharmacy versus another, the pharmacist can't really do their full job unless you'd actually have a conversation one-on-one with them about all of your medications, because we don't get to see medications that you fill somewhere else. So I think that would be one improvement. And I'm sure again, we can see controlled substances that people fill. So I would think it'd be very easy to be able to see, what people get filled for everything. I do know sometimes that when you go to like certain physician offices and certain hospitals, I believe can actually see everything that you filled, or like can kind of see like a history of what you've filled. But as far as like what the pharmacies themselves can see, we can't see everything. So I think that would be one thing that would be very beneficial.
Because like you said, that's been done with narcotics.
Exactly.
So, yeah, because it's like when patients come into the hospital, sometimes they don't know what they take.
Yes.
They don't know. I take the red pill.
Yeah.
Or I'm just like, there's so, or, they just have or they know the name of the medication, but not the dose, not how many times a day they take it. Yeah. I'm like, well, it's, but then other people come in and they have a list of like everything, with how last time they took it and everything. So
Yeah.
yeah, that would be helpful to have a central location where all of their medications are. From
Yeah.
different pharmacies for sure. So, anything else you want to add? Anything else we didn't cover that that you want to bring up?
I don't think so.
Now, does your pharmacy, do you work just locally, or do you do you have customers that are not here local that you send stuff to, or?
So we're licensed in the state of Florida. So, and there's different regulations, of course, depending on whether we bill insurance or not. So if you're looking at getting like your manufactured medication through your insurance, then our hands are kind of tied at that point. You can either pick it up or we can deliver it to you. But then like our delivery range is obviously mostly just Sarasota. But if we're talking about like the hormone replacement therapy, the compounded medications that we do not, we're not contracted with insurance companies to bill them for the compounds. So with that being said, we're allowed to ship within the state of Florida. So I could, in theory, anybody in Florida, if they get a prescription sent to me and we fill it for a compounded prescription or anything that's not going through insurance, then we could ship it to them.
Can you get licensed in other states or not?
Yes.
Is it probably difficult to?
It's different for each state, but a lot of times it's like, so when I looked into it before, you get the pharmacy license in that state, but it's more than that. It's like a pharmacist on duty. So like just say I would have to get licensed in that state as well. So that's kind of the limiting factor. Like it's easy enough to get the pharmacy registered in other states, but the pharmacist, I would have to study the laws for each state because I'm considered a pharmacist in the United States, but as far as each state goes, and if I'm sending a specific amount to one particular state, I would have to be licensed in that state as well.
I was just thinking there's so many snowbirds that come, they're constantly traveling back and forth.
Yeah.
Yeah. So, well, if you can just take a minute and, let everyone know how to get a hold of you and where your two pharmacies are located and, website and anything like that.
So I have mine completely memorized. Sarasota Apothecary. We're down in South Sarasota. Our address is 8620 South Tamiami Trail, Sarasota, Florida, 34238. Our phone number is 941-218-4090. So yeah, and then you could always go to our website, which is just SarasotaApothecary.com, and then also our email address if you wanted to reach us that way. Again, it's the name of the pharmacy, so it's SarasotaApothecary@gmail.com. And so you could always reach us that way. The location that we're actually sitting here right now, this is Gulfcare Pharmacy. This is up in Lakewood Ranch, Florida. And it's actually attached to Lakewood Ranch Medical Center in Office Building 1.
Mm-hmm. Which there's is that expanding, that huge building that's out there?
Yes, I believe so, yeah.
Yeah, I know. I came in, I haven't seen it. I haven't been by here in a while, and I was like, man, that hospital's getting big.
Yeah, absolutely. Yeah, there's just, with all the influx of people moving to Florida, it's just everywhere in this particular area. I would say from Tampa probably down to Naples, is just everywhere is just expanding.
That's great. So, well, thank you for coming on and, sharing about the pharmacy world and hormone replacement and everything. And
yeah, thank you for having me.
So,
absolutely.
You.